I have. Good evening, sir. Ajay Khanna, sir.
Good evening, everyone.
Dr. Shenoy.
Khanna sir, good evening, sir.
Good evening, sir. Hi, sir.
Sir, good evening, sir.
Good evening, sir.
Dr. Ajay Khanna, Dr. Rajiv, sir. Namaskar, sir.
Sir, good evening, sir.
Good
Rajiv
evening.
sir, good evening, sir.
Good evening, sir.
And I think we will set the ball rolling. Rajgopal sir, do we have your case first or the thyroid first, sir? Thyroid, can we have it first, sir?
Yes, sir. We'll go for thyroid first.
Okay, sir. Okay. So, good evening, friends. Senior faculty here. The invited faculty, Professor Rajiv Sinha, sir. Rajiv Sinha, sir, is just reaching home. He should be joining us anytime shortly. We have Dr. Lamture, sir, if he should come. And we have Professor Arul Kumaran, sir, from Professor of Surgery from Government Salem Medical College. And we expect the other faculty to join shortly. Rahul Sinha sir is joined already. I think he is driving, so he is kept on quiet mode. We have our regular senior faculty, Khanna sir, Rajgopal sir, Karnakaran sir, Srinivasan sir, Dr. L. Sridhar, Dr. Rajiv Sahai sir, and a galaxy of faculty here. And people, we warmly welcome all of you for the people who have joined in the YouTube also. Today we have two important presentations. One is contributed by the KMC Manipal, the abdominal wall swelling from the Department of Surgery. And we have the other case kindly contributed by the Department of Surgery at Government Salem Medical College. So we will have Dr. Praveen's presentation first. Praveen, can you start sharing your screen and start?
I just want to introduce to Dr. Ajay Khanna and Dr. Rajiv sir and Karnakar sir.
Sir, I'm sorry,
Dinesh.
Dr. Dinesh, I'm sorry, I forgot.
Dinesh is our head of the department, sir. He has joined today, sir, in the group. Dinesh.
Sir, good evening, sir.
Good evening, Dr. Dinesh.
Sir, I
Good evening, sir.
did not introduce
Welcome,
you
Dinesh.
properly.
Welcome.
Thank you, sir. Thank you.
Faculty, kindly take over.
So can I start, sir?
Yes, ma'am.
Good evening, sir. I am Dr. Praveen Kumar, final year postgraduate from Government Mohan Kumar Mangalam Medical College and Hospital. My guide is Professor Dr. P.V. Dhanapal, sir, and Associate Professor Dr. M. Arul Kumar, sir, and my head of the department is HOD is Dr. Vijay Kumar, sir. Today I am going to present a case of multinodular goiter. A 40 years old female, Mrs. X, came with chief complaints of swelling in front of neck since 1 year. History of presenting illness: she was apparently normal 1 year back. Then she noticed painless swelling in front of neck, which was insidious in onset, gradual in progression, and has attained the present size. There is no history of any dysphagia, dyspnea, or hoarseness of voice. No history of intolerance to heat, increased sweating, weight loss, tremors, chest pain, palpitation, easy irritability, or increased bowel movements. No history of excessive weight gain, constipation, or intolerance to cold. No history of any bone pain, dyspnea, or cough with hemoptysis. Past history: she was not a known case of type 2 diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy. Previous history of sterilization done 15 years back. There is no history of any irradiation to the neck during childhood. Personal history: she consumes mixed diet, no history of any sleep disturbances, no history of bowel and bladder habits. History of bowel and bladder habits are normal, no history of any food or drug allergy. Menstrual history: she attained menarche at 15 years of age and she has a regular menstrual cycle. Obstetric history: she has gravida 2, para 2, and abortion 0. A general examination: after getting consent, patient was examined in presence of female attendant.
Hang on. Dr. Praveen.
Yes.
Please,
Yes, sir.
we'd just like to ask you something on history.
Yes, sir.
Right.
Praveen, go to your first slide. Go to your first slide.
Yeah.
There are history. Yes, please, sir.
Yes, sir.
Yeah, next slide, please. Praveen, this is a postgraduate exam, right? So just detailing out all the symptoms of hypothyroidism or secondaries is not important. Just say that the patient is clinically or is not having any history of hypo or is clinically euthyroid. right?
Okay, sir. Okay.
And there are no mentions. So you can, if someone asks you, then you can just enumerate all of them.
Okay, sir.
And also any drug history.
No, sir.
You talk about allergy, but you must she must be taking some medication, something or the other. So you must mention that also.
Okay, so I just started food to drug allergy, but doesn't
Yeah, you're taking off drug allergy, but is she on any medication?
Okay, sir. Okay, sir.
Right. So
She
you must mention
doesn't
that.
take any medications for the above complaints. Okay.
Yeah,
Sir.
so just mention that she's not on any medication.
Okay, sir.
That's right.
Shall I proceed, sir?
Praveen,
Okay. Good.
okay, your chief complaint, you said it is since 1 year, no?
Yes, sir.
Yeah. Is that a correct statement?
She noticed the swelling.
Not since. It cannot be since. Since is a definite entity, isn't it? So you will say it is for 1 year, Jay.
Okay, sir.
You understand that?
It is
Okay.
since 25th of September, right? Like that.
Okay.
You have taken the history of irradiation to the neck in the childhood.
Yes, sir.
Can you tell what are the reasons that if somebody may have the radiation in the childhood?
Patient may get lymphoma during childhood. History of lymphoma. For that, she get an irradiation.
One is a lymphoma. Do you know any other, even the non-malignant causes where the radiation used to be given in the past, but no more, it is not given now?
For
Even for the acne, even for the
acne
acne,
vulgaris.
very
Okay,
severe
sir.
acne, sometimes the radiation was given.
Okay, sir.
In the family history, what have you taken the family history in this patient?
Yes, sir. Actually, there is no significant family history, sir.
So
It's not
what you were interested in the significant family history?
If there is a medullary carcinoma thyroid, it may run in family, sir. Or due to iodine deficiency.
So are you interested only in the family? If somebody has got a multinodular goiter,
Yes,
you are
sir.
only interested in the family members suffering from the multinodular goiter, or you want to see something else also?
Other malignancies like
Endemicity of the goiter.
iodine deficiency.
So you have to ask about, in the surroundings, that if somebody has got the goiter or not.
Okay, sir.
Yeah, not only the family one only.
Okay, sir.
Okay. Yeah. You can go on the examination now. Yeah.
Okay. So, Praveen, sir said
sir.
endemicity. What do you mean by, when is a disease called endemic? When you say a disease is endemic? Praveen, are you there?
Yes, sir. I'm
Yeah.
hearing, sir.
When do you say a disease is endemic? What percent of the population has to be affected to be called endemic?
There is a constant presence of disease in that area, and there is a constant presence of some specific disease in that area.
Everyone couldn't be having goiter. There must be a certain percentage of the population has to be affected by it when you call it endemic. It's 10% of the population. If
Okay,
10
sir.
greater than 10% of the population is affected, it's called
Okay,
endemic.
sir. Okay, sir.
Yeah, go on.
General examination. After getting informed the consent, patient was examined in presence of female attendant. Patient is conscious, cooperative, oriented, afebrile, and hydration is good. Patient is moderately built and well nourished. Her pulse rate is 88 per minute, regular rhythm, normal volume and character. Blood pressure is 130 per 80 mm mercury. Respiratory rate is 18 per minute, and saturation is 90% in room. There was no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. No eye sense, no tremors noted. Examination of neck. On inspection, a swelling of size 10 cross 8 centimeter noted in front of neck, extending 1 centimeter below thyroid cartilage and 1 centimeter above suprasternal notch, and from medial border of both sternocleidomastoid muscles. Swelling is nodular surface with well-defined borders. Lower borders are seen. Swelling moves upward with the decluvitation and does not move protrusion of tongue. The skin over the swelling is normal. No scars, no visible dilated veins or pulsations, no sinuses or discharges. Pumbleton sign is negative. On palpation, no warmth, no tenderness. Inspect findings are confirmed. A swelling of size 10 cross 8 cm noted in front of me, extending 1 cm below thyroid cartilage and 1 cm above suprasternal arch and between medial borders of sternocleidomastoid muscles. It is firm in consistency with bosselated surface. Trachea appears to be in midline. A coccus test found there is no stridor. Bilateral carotid felt equally on both sides. No cervical lymph node enlargement. Lower border is palpable. On percussion, resonance noted over the sternum. On auscultation, no carotid bruit or bruit any head over thyroid. Other systemic examinations were found to be normal. Summary: a 40 years old female came with complaints of swelling in front of neck.
Do you have any picture of the patient?
Sir, it's in mobile, so I can't able to add in the slides.
From the mobile, you can actually save it to your wherever, and you can incorporate. Anyway, leaving apart that, Praveen,
Yes, sir.
see, you go to your one slide before. Yeah. You started palpating, then went to trachea, then you went for coccus. Next slide. Then here you mentioned carotid lymph node, then you have come to lower border again. See, these are not accepted in the post-graduation. You
Okay, sir.
everything related to the swelling, you complete, no? Everything.
Okay, sir.
All typical. There's no difference between PG, UG as far as these things are concerned. Size, shape, surface, border, no other swelling, lower border, whatever you want to say, most with deglutition, everything.
Okay,
Only all those things you complete related to the thyroid, whether it's you want to say Lahes method, Cocker's method, whatever you want to say, finish off that. Once that is done, then go for trachea, carotid, lymph nodes, like that. Okay.
Okay, sir. Okay,
and
sir.
Always remember, we always told several times, please put some slide numbers. Slide numbers. So
Okay,
that you
sir.
want to say, no, I want to go to slide 12, 13, like that. Easy for people to pick, especially in this Zoom meet. Okay, yeah.
Okay, sir.
Praveen,
Yes, sir.
you said on inspection the swelling is nodular, but on palpation you say it is bosselated. So what
Yes,
do you
sir.
mean by nodular and what do you mean by bosselated?
Sir, actually on nodular surface on palpation we tell that as bosselated. It is
Look, you cannot confuse a nodular swelling with a bosselated swelling. You cannot, even by inspection. Right? A bosselated is a large, small balls-like things which are swellings around the neck. And nodular are small. There's nodules are small, right? So you can't confuse with that.
okay.
And you said the trachea seems to be central on palpation, but you must confirm the position of the trachea by auscultation also, right?
Okay, sir. Okay, sir.
Okay.
And what is the meaning of no warmth? You said in this. Go back to this slide.
Yes,
What
sir.
is no warmth?
So in case of thyroiditis,
So what you will say?
or if the thyroid is more vascular, we may feel warmth over the area.
What do you say? What is the term which is used for that? Is that the no warmth?
Inflammation.
No. No local rise of temperature.
Localized rise in temperature.
No local rise of temperature.
Okay, sir.
And then you are saying swelling of the size 10/8 extending 1 centimeter below thyroid cartilage. Thyroid cartilage is a broad structure. So is it the upper border of the thyroid cartilage or what you want to say?
From upper border of thyroid cartilage, sir.
So you have to define that.
Okay, sir.
Okay. It is from the upper border of the thyroid cartilage. Okay. And should you do a Cocker's test? Is it a good test to do?
No, sir. Patient may develop, if there is any tracheomalacia or
Yes, Cocker's, it should be better avoided. Just like in the DVT, you never demonstrate all those Homan tests and all those things.
Yes, sir.
Okay, similarly here also in the Cockers test, it should not be demonstrated here.
Okay.
Okay, examiner
Okay.
asked, that is okay, but I think it is not good for the demonstration purpose.
Okay, sir.
And where did you auscultate the brew?
For thyroid, sir.
Yeah, we are talking about the thyroid only. Yeah. Where did you auscultate the brew?
Over the dominant area of the thyroid.
Not on the dominant area.
Why do you get bruit? What is a bruit?
Sir?
What is a bruit?
If there is more, if the area is more vascular, we can hear some noisy sound.
Is it, suppose it's not vascular, suppose it's not very vascular, then can you still get a bruit?
No, sir.
You can. It is because of turbulent flow, isn't it?
Okay, sir.
Right. So where will you auscultate it?
Over the pole, either superior or inferior pole, or the
So you-
margin of the thyroid.
Decide which pole, upper or lower pole?
Upper pole, sir.
Why?
So what was the method of examination, Praveen? Which method did you start your examination, the palpation? What are the various methods that you know of?
Lahey's method and Kryls method.
Lie is one. Number two.
Kryls method, sir. If the swelling is too small to palpate a nodule, we will use a Kryls method with the help of thumb finger.
So Kryls into and any other? In a short neck.
Physiologist method on inspection.
So what do you do in that?
Ask the patient to keep the hand the occipital region and ask the patient to extend the neck and check for visible swelling on inspection.
Okay, so how do you examine the posterior part of it? This appears to be large swelling. 80 to 10 centimeters appears to be a very large swelling.
Okay.
So
Sir.
how do you examine the posterior part of the swelling? Standing in front of the patient, standing behind the patient. So what are the your position? What are the patient's position? Because examination of the thyroid is very specific.
Yes, sir. So actually, for palpation, we should go behind the patient, ask the patient to, with the help of, we will keep the thumb finger over the occipital region, and we will slightly passively flex the head, and we will palpate the thyroid with the other 4 fingers on both sides, sir. Palpate both the lobes of thyroid.
Okay, so it was uniformly nodular or bossulated, whatever you want to call it. You like to call it bossulated or nodular? What do you like to finally call it?
Nodular, sir.
So was it uniformly so? It was areas which were smooth, or it was having
more
variegated,
nodular,
huh?
more nodular over right side than left side.
So even that was a dissymmetry. It was not symmetrically enlarged. So the right lobe was more enlarged than the left lobe. That's what you want to tell us?
Yes, sir.
Okay. And how do you palpate the carotids? Where do you palpate the carotids?
I have to draw an imaginary line from mandible to sternoclavicular joint, and the junction, the level of cricoid cartilage, I check for pulsation of common carotid artery.
So, I mean, the whole, you palpate the whole length of the carotid, just part of the carotid.
Part of the carotid, sir, common carotid.
Okay, so where do you isolate it? Where do you localize it? Near the mandible?
No, sir. From cricoid cartilage, lateral to the cricoid cartilage is medial to sternocleidomastoid.
How is it related to the sternocleidomastoid? Carotid sheath?
Sir?
Is it posterior to the sternocleidomastoid? It's anterior to it? Anterior to the anterior border?
Anterior to the medial border of sternocleidomastoid.
Okay. So
medial to the medial border of sternocleidomastoid.
Okay.
Do you palpate it by one finger or you use multiple fingers to palpate?
We'll use both the hands of from.
You have to at least put 3 fingers. At least 3 fingers has to be there to palpate that. Okay.
Okay, sir.
So in the middle part of the sternocleidomastoid, you have to feel, And then you have to tell about, you are not only interested that felt equally on both sides. You are interested in whether it is displaced or not.
Okay, sir.
Okay, because it's a big.
If a large swelling, the likelihood is that it may probably be displaced. 800 centimeters is quite big. It's not a small swelling.
Yes, sir.
Okay, coming back to the same brew, that where you feel, you will hear it on the upper pole, not on the lower pole.
Okay,
Because
sir.
upper pole is the superior thyroid vessels which are there. They are superficially located. While inferior thyroid vessels, they come from the posterior side of the carotid sheath.
Okay,
So
sir.
they are not on the lower pole. They are on the side of that. Only in the inferior pole is the vein is there, but not the artery. While on the superior side, you get both the artery and the vein there.
Okay, sir.
So that is why you have to always do the auscultation over the upper pole of the thyroid,
Right.
not in the other areas.
Okay, sir.
Praveen,
Sir.
can you go to the general examination?
Yes, sir.
Next slide. See, in general examination, I feel you have to note the weight of the patient. Though it is not associated with this case, in
Okay,
case
sir.
of hyper or hypothyroidism or hypothyroidism, how can we measure the patient on treatment is becoming euthyroid?
One is by biochemical.
Leave it.
Whether-
We are speaking clinically.
Okay, sir. By clinical improvement of symptoms,
And that
patient
is what.
symptoms, and
How? See, there is one thing called sleeping pulse chart. Am I right or wrong?
yes, sir.
Sleeping pulse chart. If the sleeping pulse comes from 110 or 120 to 80 or 90, that means the patient is improving and moving towards euthyroid from hyperthyroid. Yes or no?
Yes, sir.
So it is a subjective test. Some staff nurse may take a sleeping pulse chart by 11:30 or 10:30.
Okay, sir.
Even before the patient sleep deeply. Some nurses may take by 2 a.m. but when the patient is sleeping deeply. Am I right?
Yes, sir.
So it is a subjective. Whereas when you measure the weight of the patient, so
Okay,
if the patient gains weight, in case of hyperthyroidism,
yes, sir.
if the patient gains significant weight, that means the patient is moving towards euthyroid. Am I right?
Yes, sir.
So we have to note the weight of the patient. That
Okay, sir.
gives very good information.
Okay, sir.
Yes, that's all.
Dr. Dinesh,
Sir.
Dr. Dinesh,
Yes, sir.
you want to ask any questions? Please.
Dr. Praveen,
Sir, yes, sir.
in the examination, you mentioned about the nodularity.
Yes, sir.
Can you please describe it more detail, right side, left side, how many nodules you feel, and what is the consistency of the nodules?
Sir, nodules, it's actually firm in consistency, sir. On all the lobes, it's more on the right side. The one nodule is more prominent on the right lobe of thyroid, sir, when compared to left lobe.
Okay, how does this nodules develop in the thyroid?
So actually, due to increased release of thyroid stimulating hormone, there is an initially there is a diffuse hyperplastic goiter. Then it goes to there is a fluctuation of thyroid stimulating hormone, which causes both active and inactive nodules. These active nodules become more vascular, and there is an hemorrhage and necrosis. And this necrotic nodules will coalesce to form nodules and forms nodular goitres. And the internodular tissues are active to develop for release of hormones.
Okay, what is the importance of knowing a consistency in the thyroid?
If the consistency is turning from firm to hard, it may turn to malignancy. We can suspect that it may turn to malignancy. Or if it is, sir.
Yeah, what probably Dinesh is asking you is that Short duration, if it is hard, definitely you will consider malignancy.
Malignancy. Yes, sir.
But suppose goitre is 20 years duration, one area is hard, what do you suspect? No recent increase, any possibility?
Calcification.
So one or two things to be kept in mind. So especially he has raised important things. If you say nodular goiter, that too you are telling bosilated means very large one nodules. You have to mention right lobe, left lobe. Is it a symmetrical enlargement or asymmetrical enlargement? Is it a variable consistency or any necrotic area or isthmus? How is the isthmus area? All these details you should give.
Okay, sir.
Praveen,
In general examination, eye signs and the tremor are not the part of the general examination. Okay.
Okay, sir.
Where you have mentioned here, that is not the part of the general examination.
Okay, sir.
These are the specific things you are going to examine here, not
Okay,
as a
sir.
general examination. Okay.
Okay, sir.
Now tell, how did you examine the neurological system of this patient? What are the things you examine in the neurological system of a thyroid case?
If we're suspecting a primary thyrotoxicosis, history-wise, we will ask the patient sleep patterns. Sir.
Tell about the examination. I'm asking what are the signs you are going to tell about the neurological
Tremor,
examination.
resting tremor.
Yes, tremor is one. Yes.
Then insomnia. See.
No. Signs. Insomnia is a.
See, try to think what symptoms which patient will complain to you, primary thyrotoxic especially. Suppose you might tell muscle weakness or all that. Can you think properly and say neurologically what are the things you assess?
In a neurological
Check
examination,
for
you check
proximal
for the
myopathy,
motor.
muscle weakness, proximal muscle weakness.
Yes, so proximal myopathy may be
Muscle
there.
weakness. Yes,
Okay,
sir.
so you check for the motor system, you check for the sensory system, you check for the autonomic system, you check for the tendon reflexes. So all these are the part in the case of thyroid. What tendon reflexes you are going to check?
Ankle jerk. There is a delayed ankle jerk in case of hypothyroidism.
You can get that. It may be exaggerated or it may be delayed. Both may be there, depending upon what is the situation of thyroid. Okay. How will you know the patient's autonomic system?
Symptoms wise, bowel disturbances is there, sir. And on examination, we will check for heart rate, whether it's tachycardia or bradycardia.
You shake the hand with the patient. What happens?
Sweating is there.
Yes, excessive sweating is there.
Excessive sweating is there.
Diaphoresis. So that is one of the very important features which is there. They are all related to the neurological system.
Okay, sir.
Okay. Praveen,
Yes, sir.
It was all the teachers have asked you about proximal muscle weakness. How do you test for proximal muscle weakness?
Ask the patient to squat and
right. So you should say that. Also, you've not examined his knee reflex, his hyperreflexia, which has to be mentioned.
Okay, sir.
And pretibial myxedema, you have to look for, which you've missed. So all these things have to be enumerated in your examination.
And again, generalized lymphadenopathy, that should be not come here. Okay.
Okay, sir.
At the end of your thyroid examination, you should specifically mention no significant lymph nodes, drainage area.
Okay,
what are the drainage area? Which specific nodes you have checked in this patient?
Pre-laryngeal and pre-tracheal lymph nodes.
How will you make out that in a large goiter? We have no picture of this patient, but you said so huge goiter, bosilated surface.
Actually, we'll check it by investigations through CT scans. Pre-laryngeal nodes.
No, don't.
Clinically, we unable to.
No. What other nodes you are looked for?
Deep cervical nodes.
No, deep cervical, correct, man, but post level, specifically any lymph
Level,
nodes.
level 2,
Hmm.
level 3, and level 4 nodes.
Level
2, level 2, level 3, and level 4 nodes, sir.
better to say level 3, 4 first. Okay, 3, 4.
Okay, sir.
Then of
Okay, sir.
course, not that you can't get 2 and 5, etc.
Okay, sir.
Only
3 and 4.
3 and 4. Pretracheal, prelaryngeal, difficult to make out if you have got a large pattern.
Yes, sir.
So go to the last. Go to the last slide of palpation.
Yes, sir.
Yeah, just tell me importance of each. Sometime they ask you,
Sir, importance of
when do you do Lahes test? Lahes method.
the lobe is if we specifically check for a right lobe swelling, we will put the
May I request those who are not asking questions, switch off the audio, please.
अच्छा आप उधर जा रहे हैं ना मिशा मैम के वहाँ ठीक है हम तो यही देख रहे हैं वो पेज रिपोर्ट रूम पे
This iPad and 1+70, please switch off your audio for some time. Okay, thank you. Now, so when do you, these are some of the questions. When do you do Lahes method?
Sir, if we specifically want to check for swelling in either a right lobe or left lobe, we will push the lobe towards the opposite side and palpate with the opposite hand.
So when do you look for the Kryls method?
In case of small nodule,
Suspected nodule.
Suspecting small nodule, with the help of some finger, we will palpate it.
And each test you should know. When do you do the Pigelos method? How do you do it?
In case of short and obese individuals, you will ask the patient to extend her neck, and keep her hand behind the occipital region, and we will inspect the swelling.
Yes. Diagnosis. Anybody? Any other question, sir?
Praveen, you told you percussed over the manubrium sternum. Is it indicated in this patient, or just for completion's sake you told that?
For completion's sake, I just told that, sir. As a lower body is clinically palpable and it doesn't show any retrostinal extension. Mostly percussion shows resonant only, sir. But for completion's sake, I just added the slide, sir.
Okay.
You can go to the diagnosis now. What
Okay,
is the diagnosis? Yeah.
It's a case of a non-toxic, non-malignant multinodular goitre.
Okay. Any differential diagnosis you want to keep?
How do you know that it's not malignant clinically, Dr. Praveen?
Sir, consistency of the swelling is firm and duration is only 1 year, sir.
Does the duration?
And there is no.
Yeah, please go ahead. Please go ahead.
There is no any lymph node enlargement or any other symptoms of metastasis or the other areas.
Like what did you look in your patient? What is the age of your patient?
40 years, sir.
So what do you suspect, if at all, in a 1 year goiter or so?
Sir, if there is any lung metastasis, we can suspect
lung metastasis. Is it that common from the thyroid?
No, sir.
Before that, something else you will get. You said lymph node, okay, accepted. You said hard consistency, accepted. What I expect you to answer is,
Skull
sir,
swelling.
sir, in the history wise, there is no hoarseness of the voice or there is no rapid growth. You
Okay, sir.
understand?
Okay,
History
sir.
wise. Clinical
Okay, sir.
examination, you said no, there's no hardness,
Consistency. Nodal enlargement.
no
Carotid.
lymph node, no significant node enlargement. Yes,
Carotid.
yes.
There is no. The carotid artery felt equally. It
Multiple.
shows there is no
And-
engulfment of carotid.
And especially bone metastasis, flat bones. That you should tell, not
Okay,
lung.
sir.
You
Okay,
can
sir.
quickly feel the scalp, ribs, sternum, etc.
Okay, sir.
So this is how you should tell in the examination. History
Okay,
wise,
sir.
clinical examination wise, so I feel it is non-malignant, non-toxic multinodular goiter.
Okay, sir.
Praveen, suppose this patient was toxic,
Yes, sir.
what would your diagnosis be then?
Secondary thyrotoxicosis.
Okay. So what is that called?
Plumber's disease.
Excuse me?
Sir, plumber's disease.
Yeah, Plummer's disease.
What is the difference between a sudden increase and the rapid increase?
Duration of swelling. Rapid increase within hours to days.
सडन इंक्रीज में भी हो सकता है क्या चेंज? मतलब
So sudden will mean what and rapid will mean what?
Maybe an ongoing hemorrhage inside the goiter.
That will lead
It
to
indicates sudden rapid increase in
sudden, yeah. So within few hours or within a day or two, if there's a rapid sudden increase is there, so that is the hemorrhage.
hemorrhage.
The rapid is the malignancy.
Okay, sir.
Yeah. Okay. So how we are going to work up for this patient?
So we'll do routine blood investigations, then thyroid.
What is
function
that
test,
routine blood investigation?
complete blood count, RFT, R-based serum electrolytes.
Why you want to do a complete blood count in this patient?
Hemoglobin to check for hemoglobin status.
You know, whenever there is any disease is there, the first thing is you have to make the diagnosis. Okay,
Okay,
so your all investigation initially should be directed toward making a diagnosis.
Okay, sir.
So in a case of thyroid, just like in the breast, we have got the triple examination. What is there in the thyroid?
Have
What is that called? Like in the breast, we say it's a triple examination, triple assessment.
Yes, sir.
And similarly here in the thyroid, it is the quadruple assessment.
Okay, sir.
Okay, so what is that quadruple?
We'll do thyroid function test.
So thyroid function test is the fourth one here, which is not there in the blood.
Okay, sir.
Rest the things are the
ultrasound.
same.
Ultrasound, neck.
Yes, ultrasound is there. FNAC is there.
FNAC.
So clinical examination, ultrasound, FNAC and the
FNAC, thyroid function test.
So in this patient, what investigation you will do first?
First, I will do we'll check for FNAC from the thyroid, sir.
In a multinodular goiter, you will do FNAC.
First, I will check, do X-ray neck epilateral.
No. Confine only to these things which we are talking. So always you have to do the thyroid function here.
Okay,
and in a clinically suspected non-toxic goiter, what type of the thyroid function you will do?
Free T3, T4, TSH.
No, the first investigation, the screening one is you do the TSH examination.
Okay, sir.
Okay. If you find the TSH is abnormal, then you may go for the other things.
T3 and T4.
And if you are given a choice to, in a case of a toxic goiter, if you have to do only one investigation, which one you will do for the thyroid function?
T4 level.
Which T4?
Free T4.
Free T4. Yes. Okay, so out of free T4, total T4, free T3, total T3, you will do the free T4. Jay.
Okay, sir.
Right. So that should be a first investigation. Second investigation?
Ultrasound neck.
Ultrasound of the neck. Yes. Then third will come the
FNC.
FNAC. So
Okay,
in a
sir.
case of multinodular goiter, what precautions or what things you are going to do for the FNAC? You know, if it is solitary thyroid nodule is there, the things are different. But if the multinodular goiter is there, then how you are going to do the FNAC?
FNC over suspected nodular swelling to rule out malignancy.
How do you suspect?
So, ultrasound guide through ultrasound, if it
It
shows.
has to be ultrasound guided one.
Yes, sir.
Okay. So it has to be always the ultrasound guided FNAC.
Okay, sir.
What information is the ultrasound going to impart to you, Ravi?
Whether it shows whether the swelling is a solid or cystic component. Shows whether the number of nodules and vascularity. Then features of
Number of nodules
malignancy.
going to make any difference in any way?
No, no, sir.
So you're more concerned with the vascularity is number 2?
To rule out suspicion of malignancy, like hypoechoic calcifications.
Are calcifications a major role to play in the diagnosis of malignancy of the thyroid?
No, sir.
What else?
Then cervic and lymph nodal enlargement to rule out to check for lymph node enlargement and carotid pulsation.
The sheath, the carotid sheath relationship is involved or not. What else? Any information about the trachea? Is the ultrasound going to
X-ray. Tracheal infiltration.
pardon me?
Tracheal infiltration.
Infiltration.
No, sir.
Any distortion in that particular area, if you're thinking in terms of malignancy?
Tracheo.
So basically, in a multinodular goiter, the ultrasound is only going to help you in the extent of the disease, and number 2, the variegated parts which can be delineated by the ultrasound. Those cystic and those solid areas which can be seen, the infiltration which can be seen, the degree of tracheal involvement in the sense whether it's causing compression or not, these can be seen on an ultrasound scan.
Okay, sir.
And then you go in for FNAC. So what are you looking for in FNAC? How would you categorize the FNAC findings?
I mean, what is thyroids?
Thyroid imaging reporting and data system.
So now the ultrasonologist will tell about that particular nodule which is there, or that what is the thyroids for that.
Yes, sir. Thyroid 0 to 6 they score as if it is 0, it's
okay. Tell about the FNAC. Yeah, Dr. Sinha was asking. Tell about the FNAC.
So basically, just like BRADs, on the TRAD is also there, and not only for the ultrasound, can also be taken up for the CT or the MRI. That can also be classified based on the TRIRADs. Okay, so on FNAC, how are you going to categorize the findings?
If it is 0, it's benign. 1 is probably benign.
What do you call this? What do you call this classification?
Thyroid, sir. Thyroid imaging reporting and test data system.
No, FNAC. FNAC, Dr. Sinha is asking.
Bethesda classification.
Okay, so how many groups in that?
6.
6, yes, that's right. And as you go up the scale,
5 is probably of malignancy.
5 is probably malignant. So then what is 6?
proven.
Yourself said 6.
It's proven malignancy.
So is this classification going to help you at all in prognostication or in therapeutics? What? How is it going to help you? Why at all do it?
To plan the treatment, or treatment plan can be helpful.
So one is to prognosticate, and number 2, more important, a therapeutic implication. Okay, so that's the most important reason why you like to go in for a FNAC of this patient. So you have done a clinical examination, then you did an ultrasound, then you did a FNAC. And of course, in between you did, or rather start, you did the thyroid function test. Is there any role of going in for any kind of antibody test in this?
If you're suspecting primary thyrotoxicosis, we'll check for thyroid stimulating hormone antibodies. If there is suspecting.
In a patient with primary thyrotoxicosis, which antibodies are you looking for?
TSH receptor antibody. Thyroid stimulating hormone, immunoglobulin antibody. Thyroid stimulating hormone.
What are the 3 major antibodies that you're looking for, whether it's a thyroiditis or if you're looking at a primary or a Graves' disease? What are the 3 antibodies that you look for?
Thyroid stimulating receptor immunoglobulin antibody, 1. Another 2.
Especially in a Graves' disease, you're looking for some kind of a receptor antibodies. Which receptors are we talking about?
TSH receptors, sir.
TSH receptors. Yes. So you're basically looking at antibodies for the TSH receptor.
TSH.
When a patient with thyroiditis, you're looking at the
peroxidase.
Anti-thyroglobulin.
Peroxidase.
These are the 2 antibodies you're looking for. So is there any role of any antibody in this patient, especially when you think of a secondary, MNG, which is non-toxic?
You can check for thyroglobulin level.
Thyroglobulin. Why would you look for that? How is it going to help you?
If you're suspecting MNG can turn into follicular carcinoma, then the thyroglobulin level will get raised.
In this patient.
Is it a routine practice in your place, Dr. Praveen? You have a thyroid patient like this, you send thyroglobulin at this stage, or?
No, sir.
So better to tell no what is practiced in your place. So what is the commonly, I think PGs can expect if it is 3 or 4. What do you mean by that? Bethesda 3, 4 means what? You said 5, you said probably, no? Probably.
Yes, sir.
So 3.
Dr. Praveen, it comes as Bethesda 3. What is going to do? Thyroid 3 and Bethesda 3.
Sir?
FNAC, if it is Bethesda 3 classification, okay?
Okay, sir.
What are you going to do? What is your next step? Did you hear me?
Yes, sir.
Thyroid 3, Bethesda 3 means what are you suspecting? Some follicular cells of what? Atypia. Undetermined. So
okay, sir.
What is your plan now at this stage? That's what is the question.
If it is Bethesda 3, what is your approach? If it is Bethesda 4, what is your approach? Is it going to change or is it going to remain same for both?
You should rule out malignancy if it is Bethesda 3 and 4.
What is the chance of malignancy if it's Bethesda 3? What is the chance of malignancy if it's Bethesda 4 or 5, like that, in percentage wise?
30%.
Bethesda 3, it is usually 15 to 30% chance of malignancy is there. As it increases 4, 5, it also increases like 30 to 60 and 60 to 70.
Okay.
Okay. If it is Bethesda 3, atypical cells with follicular neoplasm, follicular type, then usually a repeat FNAC can be asked. If it's Bethesda 4, you can go ahead with the surgery, suspicious of malignancy.
Okay, sir.
So that depending upon the percentage of chance of malignancy, that your management also changes. That is the role of Bethesda in FNAC,
Okay, sir.
which is linked to your management, your treatment.
Okay, sir.
So these have been already told to you. Just to tell it again, ultrasound is the first line of investigation. You are ruled out toxicosis. You should always tell ultrasound guided FNAC.
FNAC.
I think this has already clarified to you all the features in ultrasound. And then depends upon, so what you have to tell the examiner is, sir, I will wait for the FNAC report, then proceed. Why FNAC? I think has been already answer has been given. Is it okay?
Okay, sir. Okay, sir.
My question to you is, you have said such a large goiter, bossulated and all, highly suspicious of follicular neoplasm, malignant changes are probably. You want to explore this? Any other investigation?
Technetium 99.
Technetium? No. Why? In what way it will help you? See, you are such a large goiter. You most probably you plan for a total now, correct?
Yes, sir. Yes, sir.
So you only said large goiter. I am using the word large goiter. Any other investigation you want to do? If at all you want to do to better to know the carotid status, etc. What is that?
CT neck.
Because since we don't have the picture from your side, if a very large goiter, if the anatomy is distorted, if the carotids are displaced, or suspicion of a hard nodules there, that is the time you ask for a CT scan. Okay, to know the better. Otherwise, ultrasound can give you very good information.
Okay, sir.
So let us imagine the thyroid function test is normal in this patient and FNAC is nodular goiter. How are you going to proceed further?
Treatment plan, sir.
Yes.
You can plan for a total thyroidectomy.
Why total? What are the different modalities of treatment for multinodular goiter?
Subtotal thyroidectomy or a subtotal, near total or a total thyroidectomy, sir. If the whole of the thyroid.
I asked you different modalities, not different surgeries.
Okay.
Is there any other modality other than surgery for multinodular goiter? Is there a role for medical line of management or radioiodine therapy?
Radioactive ablation.
In general, not for this case, I'm asking in general, different modalities for multinodular goiter.
Okay, sir. If the patient is in thyrotoxicosis, we can try with anti-thyroid drugs, then radioactive ablation therapy, then followed by surgery.
Praveen, you should be a little careful now. Remember, this is a secondary thyrotoxicosis, if at all. Very large nodular, that too you are telling very bossulated. So, do you feel radioiodine is the treatment here in this patient, or you are talking about primary thyrotoxicosis, where there is gland is very small, right?
Yes, sir.
So here you should probably not mention such a, because we have no picture, but your description.
Okay.
Very high dosage. So only I think, sir.
Sorry, Praveen, why can't you use radioactive iodine here?
Yes.
That's the reason. Why?
The dose of radioactive iodine will be more.
No, it's nothing to do with dose. Like you said, here certain areas will be active, rest of areas will be inactive, isn't it?
Yes, sir. Only active areas will be destroyed.
If it is so the radioiodine will not help because it will not go to inactive areas.
Yes, sir. Only active areas will get a
Yeah. So your nodules remain the same.
Okay.
Praveen, coming back to your surgical options. So, what are the surgical options?
Total thyroidectomy, sir.
Can I just butt in? Would you like to operate on every patient of MNG?
No, sir. Only if it shows any signs of compression or cosmetic disfigurement, or if it's a long-standing goiter, probably it may turn into malignancy. So in that case, we'll operate. We'll remove the thyroid.
So when you say long-standing, do you have a cutoff time limit? Otherwise, the long-standing would not mean anything. It could be 5 years, it could be 15 years.
Yes, sir. Clinically, when it shows signs of compression, either dysphagia, dyspnea, or hoarseness develops.
So basically, it has to be a symptomatic MNG.
Symptomatic.
Right? A asymptomatic MNG with just a lump shown the anterior part of the neck may not require surgery. It's not a prerequisite for every patient that he or she undergoes surgery. So that should be kept in mind, right? So there are different indications for going for surgery. Now, answer what Dr. Dinesh asked you. The types of surgery that you would like to go in for.
Sir, if the whole of the thyroid gland is involved, we can proceed with the total thyroidectomy, sir.
Any other options?
Subtotal thyroidectomy.
What is the difference between these two surgeries?
If there is any normal areas of gland, we can remove it. See, we can leave it. We can leave it 8 grams of thyroid tissue, tracheoesophageal groove in subtotal thyroidectomy.
What do you mean by normal areas when you're doing? If there is a normal area in the isthmus, are you going to leave it behind, or in between the nodules? You think some normal area on table, you're going to leave it like that?
No, sir.
Where exactly you're going to leave it?
Lower pole of gland.
Lower pole of the gland. What is the difference between subtotal and near total thyroidectomy?
In subtotal thyroidectomy, both side of gland, we will leave a part of thyroid tissue. Whereas in near total thyroidectomy,
Which part? Which part of the thyroid tissue? Which part of the thyroid tissue?
Over the parathyroid region.
So basically looking at the posterior part of the lobe, right?
Posterior part.
And how much? How much?
8 grams. 8 grams in subtotal, sir.
So it's very difficult to measure 8 grams in that. Okay. And
pulp of finger.
Okay, right. Thumb.
So
basically looking at number 1, total thyroidectomy, subtotal and near total. What's near total?
Leaving 4 grams of thyroid tissue on only a single side. And we will remove all.
Praveen, before we go into all this, Praveen, sorry, I just want to interrupt you. Praveen, okay, what are the advantages and disadvantages of total and near total or subtotal?
Recurrences are in subtotal or near total.
Yeah, so what happens if there is recurrence?
During second surgery, it will be tough for
right.
For
one is that recurrence and difficult subsequent surgery. What else?
Malignancy.
Yes.
So return tissue may turn into
malignancy. Theoretically, you can go to the numerous types of thyrotoxicosis. If an examiner is asking you, fine, but you should stick to your guns and say, no, I'll do near total or total, instead of just answering to each question of theirs. You're a surgeon, you should take a decision.
Okay, sir.
I think right. now they will definitely ask you, Praveen, but you should tell mostly nowadays what is done is total thyroidectomy.
Total thyroidectomy.
Safer option. Then
you have to stick to your gun. Say this is there are options, but this is what I'm going to do.
Every surgeon aims at that, but then what happens is, as you are mobilizing the gland, especially posteriorly, as you are coming close to that nerve area where it is dipping into that thyroid membrane, tough some tissue will get. That is that so-called the varus ligament area. As you are moving there, there is a chance of you leaving behind a tissue. It may amount to near total. See, at the end of its report comes as malignancy, you have to subject the patient for a radioactive scan now. Then they will tell some tissue is remaining. So then they will ablate it. So what best answer is say total thyroidectomy.
Okay.
Sir Karunakar sir, what is your
Yes, sir. That's where I am coming, sir.
Yeah.
So the best answer is, as Rajagopal has said, is total thyroidectomy in case of such a huge goiter. Whereas as far as the benign is concerned, either you go for a near total or total thyroidectomy, not subtotal thyroidectomy, which is 10 years. The surgeons who are 10 years far behind are still practicing subtotal. No more surgeons are practicing subtotal thyroidectomy who are updating regularly. As per Delbridge and Stan Sidhu, which is the path-breaking publication, they are the people who advise the near total thyroidectomy. Following their publication, the surgeons moved away from subtotal towards the near total thyroidectomy, or either towards the total thyroidectomy. So that means almost the subtotal thyroidectomy has not been practiced for the past 1.5 decades.
Okay.
So when some surgeons ask about subtotal thyroid, they may be asking about curiosity, because of curiosity, or they may be 10 or 15 years old, not at all practicing for the 10 or 15 years. Yes, as sir said, you may try for a total thyroidectomy, but you may leave some tissue that lead to near total thyroidectomy. How much of tissue, if left, we cannot say it is a total thyroidectomy. How much percentage of thyroid is left, then we don't call it as a total thyroidectomy. Can you say by doing a thyroid scan, you do a thyroid scan, you find that some percentage of thyroid is left. How much percentage, if left, we cannot call it as a total thyroidectomy.
Yeah, I think probably now there are only two types of thyroidectomies which are there. Either you do a hemithyroidectomy or you do a total thyroidectomy. So these are only two thyroidectomies which are there. By accident, you can do a near total because you are not a good surgeon. Not a good surgeon. You are not experienced expert surgeon. That you want to save the recurrent laryngeal nerve and you want to save the parathyroid.
Yeah.
But otherwise, there are only two surgeries which are there. Is the hemithyroidectomy or it is the. So yeah, nothing like now the subtotal thyroidectomy or the lobectomy, or they have all gone now. Only these two things which are there for the thyroid surgery.
Okay, sir.
Praveen, on table, when you're doing a total thyroidectomy, how do you identify a parathyroid glands and where do you look for them? How do you save them?
Color of the gland is golden yellow to brownish in color, sir.
Where do you look for them?
Posterior surface of superior parathyroid is checked posterior to tubercle of Zucker candle.
Parathyroid supplied to which artery?
Inferior thyroid artery, sir.
All
Both superior and
parathyroid?
parathyroid. Both superior and inferior parathyroid are supplied by inferior thyroid artery, sir.
So that is why you never ligate the trunk of the inferior thyroid artery.
Okay.
Previously, that was the practice that you used to ligate the trunk.
Yes, sir.
Tell what are the other ways to find out the parathyroid?
If you dip in saline, it will float.
No, it will not float.
It will go inside.
What will happen?
It will go down.
If it is a fat globule is there, or if it is a parathyroid is there, or it's a parathyroid adenoma is there. What is the difference in the dip test?
Sir, if it is fat, it will float, sir. If it is a
Float
parathyroid,
on the
it will
surface, yes.
float on the surface. If it's parathyroid, it will
Parathyroid
go
will
down.
come in midway between. It will come midway between.
Okay,
but if
sir.
the adenoma is there, it will touch the base.
Okay, sir.
So can you give patients some dye by which you can know that this is the parathyroid?
No, sir.
What is the NIRF technique for identifying the parathyroids these days?
Sir, what?
NIRF technique, NIRAF. That's now being done very commonly. Near infrared autofluorescence, right?
Okay,
One of the
sir.
methods of identifying the parathyroid. There are a number of methods. One is anatomical identification. Second is the macroscopic identification by naked eye. Then third is the positional. And then, of course, now we're shifting to a autofluorescence near infrared. That's what is
Okay, sir.
right. So that's one of the methods of identifying the parathyroids. How would you look for the? How would you prevent injury to the recurrent laryngeal nerve?
By tracing the triangles.
Which triangle?
For superior laryngeal nerve, it's an Jones triangle, sir. For
No,
recurrent laryngeal nerve,
recurrent laryngeal.
oh, Mayor. One is Simon's triangle. Then
what are the Bayes triangle or the Riddle's triangle?
It's bound laterally by common carotid artery, and superior arm is formed by inferior thyroid artery, and the inferior arm is formed by recurrent laryngeal nerve.
And what is the triangle of concern?
It's an area where hemorrhage is more of hemorrhages occur, where inferior thyroid vein, middle thyroid vein is there. If I damage that area, hemorrhage is more over that area.
Okay, so what was the place value of these triangles as of today?
Sir?
So there was a recent article, very interesting article
okay,
that I came across, and they had done a very good study where they interviewed a number of practicing surgeons, and the ultimate result was that these triangles are basically not very important. It's basically what you're looking for is the recurrent laryngeal nerve and the superior laryngeal artery. Instead of, because these triangles, the boundaries, especially when you've got very large thyroids, it's very difficult to identify those boundaries for these triangles.
Yes, sir.
So what is more important is you should know where to look for these nerves, especially superior laryngeal, and where you're looking for the recurrent laryngeal nerve, right? And that is what you're mainly concerned with. You don't want to damage those nerves.
Okay, sir.
Okay. Right. Suppose if you've done a total thyroidectomy and you somehow left some of the tissue behind,
yes,
and you chances that there could be a recurrence. So, is there anything you can do to prevent the recurrence?
Radioactive ablation therapy.
Straight away.
You are talking about for benign condition or malignancy? What?
For malignancy.
Malignancy, that may be acceptable. What about a benign? Why would you give a radioactive iodine in that patient? What depresses the function of the thyroid tissue?
Iodide level.
So is there some method by which you can try to prevent the stimulation of that particular tissue so that it doesn't grow again? What stimulates the tissue?
Thyroid stimulating hormone.
TSH stimulates, right? So can you give something to depress the TSH level?
Glucose iodine.
Glucose iodine.
Thyroxine, sir. Suppressive dose of thyroxine.
You are not plain simple thyroxine. Not a proven method, but that could be tried.
Okay, sir.
Prevent a recurrence, especially in a benign scenario. If you got a malignant scenario, yes, you can think in terms of a radioactive iodine which can be given in these patients.
Okay, sir.
Is there any radiologist role nowadays in treating thyroid disease?
Sir, radiologist?
Is there any role of radiologist in the management of, in the treatment of thyroid disease?
Sir, if it is a cystic swelling, we can do ultrasound guided aspiration of.
Directly, I'm asking you, is there any role of embolization of arteries in the thyroid disease?
No, sir.
So recently the radiologists are doing selective embolization of thyroid arteries, especially in toxic MNG.
Okay, sir.
Okay.
Yes, sir. Okay.
Do you know what is HIFU? HIFU? This is the high frequency ultrasound. No?
Okay, sir.
So nowadays, HIFU is one of the treatments, even for the varicose veins, you can use the HIFU. So similarly, also for the thyroid, small swellings which are there, you can use the HIFU for that. So it's a non-invasive treatment for the thyroid
Okay, sir.
swelling. Now, I was asking about the parathyroid. What are the other ways to identify the parathyroid? You can give the patient the methylene blue, and that
Methylene blue.
specifically stains the parathyroids.
Okay,
So
sir.
by that, you can identify the parathyroids, and then you can use the endocyanin green also for the identification of the parathyroid.
Okay,
So
sir.
these are the various other techniques by which you can identify the parathyroid.
Okay, sir.
Praveen, just to ask you the same question which Dr. Ajay Khanna sir asked you, HIFU. Where else this is used? I will give a clue to you which benign disease. In the breast also it is now being used. Small lesions. It takes little time also for a smaller fibroadenoma, high frequency. You know, it induces the transducer, liberates the heat, and basically protein denaturation occurs, and it undergoes necrosis. That's what it is. Takes a
Okay.
long hours. So these are some of the benign conditions of the breast now treated with this high frequency ultrasound.
Okay, sir.
In your case, what complication you are expecting in the theater? So you are going to practice, you start your practice next after a couple of months, right? If this patient comes to your hospital, how will you prepare yourself during surgery?
Sir, we will check for immediate complications.
Because you may become a rural surgeon, right? I have given the clue.
Rural surgeon.
So it is not in the institute, man. So suppose if you start in your place, if it is a small hospital, so what are the precautions you will take? What are the things you will arrange before taking up the patient to the surgery?
Ventilator setup.
Pardon?
Ventilator setup, sir.
Ventilator setup.
If we can't able to extubate the patient.
So first starting from intubation. Because it is a huge thyroid, there may be difficulty in intubation. So you should ask one more attendant or any your anesthetist will prepare with video laryngoscopy or bougie or fiber optic equipments. Okay.
Okay, sir.
Then in the intraoperatively, you should prepare for blood transfer, blood replacement.
Yes, sir.
Then post-operatively, if everything goes fine, because of the huge thyroid, you may expect tracheomalacia. Though the duration is 1 year, there may be chance of tracheomalacia. So what will you do? How will you manage?
We should not extubate. If we suspecting tracheomalacia, we should not extubate the patient. We'll keep the ET tube, connect to ventilator, and we'll observe the patient for at least for 24 hours. Then we will try to extubate the patient. If the patient is not tolerating, then we'll do tracheostomy for the patient.
So
plan for tracheostomy for the patient.
So you want to extubate or you will do trial extubation?
We'll do trial extubation. If the patient is desaturating and it's not tolerating, then we'll do tracheostomy.
So at the end of surgery, what will you ask your anesthetist?
To check for vocal cut status, whether it's mobile or not.
Okay, I think we are running short of time. just what are the types of vocal cord palsy?
So either it may be unilateral recurrent laryngeal nerve, or bilateral recurrent laryngeal palsy, or unilateral combined recurrent laryngeal and superior laryngeal nerve palsy, or bilateral combined superior laryngeal or recurrent laryngeal palsy.
So instead of that, you can say it is unilateral complete palsy, unilateral incomplete, bilateral complete, bilateral incomplete.
Okay, sir.
Right? You should be ready for intubation.
Yes, sir.
Sir, I think Kanakavel pointed out we are running short of time. Anybody wants to ask any questions, sir?
Praveen, Jayagana sir, any comments or can we close, sir? I think we can go to the next one here. Yes. Praveen, you have any doubts, you can ask Praveen. No doubts.
No, sir.
So unshare your screen, we can go for the next presentation.
Yes,
Dr. Vinay is ready?
thank you, sir.
Unshare.
Yes, sir. I'm ready. Sir, is the screen visible?
You make it slideshow, pa?
Yeah, I have made it slideshow.
You start presenting.
Good evening. Thank you for the opportunity for presenting this case. I would thank Dr. Annapakurva sir to allow me to present this case on this platform, and Dr. Dinesh sir, the HOD of General Surgery in KMC Manipur. So, a 66-year-old lady, housewife, has
Yes,
come with a...
Slide is not moving.
So now, sir?
No, my slide is not moving.
See, when I what you do is, if it is not moving, click on each slide. Click on each slide, because that is the problem now. There is no slideshow, so probably something is wrong somewhere. Doesn't matter. Click on each slide.
Vinay, what you do is, can you send? I think it is moving, Vinay. What
Yes.
Rajgopal sir said is helping you. Just click on the slides on your left side.
Yes.
Okay, please go ahead. I think you are okay. Faculty, please take over.
So a 66-year-old housewife had come with the complaints of swelling over the left side of the abdomen for 10 months, associated with pain over the swelling for 1 month. This swelling was insidious in onset and gradually progressive, and the pain was characterized as dull aching, localized, non-radiating, no aggravating or relieving factors. There are no other symptoms such as pus discharge or bleeding from the swelling. Past history, significant history of excision of swelling in the month of February 2021 in the same location was there, and the swelling was to reappear after 4 months of excision.
You can be a bit louder when I place.
Yes. Personal history. The patient consumes a mixed diet. The appetite is normal.
Go
There
to
is
the
no
slide. Go to the, click on the next slide.
the patient consumes a mixed diet, normal appetite.
The slide is not moving. Go to number 3 and click it. Yeah.
The patient consumes a mixed diet, appetite is normal, bowel and bladder movements are normal, no addictions in the plate, no addictions reported. The past history, the patient is not a hypertensive, not a diabetic, or no cardiac conditions. Surgical history, there is an excision of the swelling over the anterior abdominal wall in the same location as the present swelling. On general examination, the patient was examined in sitting position.
Wait. You allow the Faculty to question you, please.
Yes.
Sir, anybody, please? When did you take the history of what was there in the previous operation? Detailed
Yes,
history
sir.
of that?
It's-
Tell about
it's-
that, yeah.
The patient actually had swelling in the month of December 2020, and she had gone to the hospital in January 2021, and she was evaluated there. And in February there was a succession which happened, and after 4 months the swelling reappeared in the same location.
What was the size of swelling at that time, and what is the swelling now?
The size of the swelling was not as a present swelling. It was comparatively less, the patient reports.
And did you ask anything that whether the biopsy was done of that swelling or not?
He said that is coming in the next few slides.
You're going to tell later on.
Yes.
Okay.
Whenever a patient gives you past history, it's a policy to be all pages. What is the duration during that time? What was the size? What anesthesia was given? Was it under local, spinal, general? Any blood loss? Any grafting has been done for this? All the details you should take up. Okay, that should be the policy.
The biopsy report of the previous case also. Did you get any previous biopsy report, Ma?
Yes, sir. The previous biopsy report.
You got them. Okay. You can write
Sir,
it.
Dr. Guru Shantappa wants to ask some questions. Sir. Please, sir.
Please, sir.
Sir, all of you, sir. Good evening.
Sir, you are welcome, sir. Please.
Yeah. Yeah, doctor, the case of excision of the stomach. Is it not?
Sir,
Yes.
1 minute, sir. 1 minute. Dr. Tangamani, sir, please mute yourself. Disturbing. Kanagwel, sir. Kindly mute Dr. Tangamani this. Please, sir. Gurushantapa, sir.
Doctor, this is a case where there is a history of having undergone excision of the swelling. Is
Yes.
it not?
Yes.
Yeah. Other than like what all you have mentioned, you should find out. Probably the treating doctor should have told the patient that what was the swelling after surgery. Invariably, they give some information. One. Second, was he advised any treatment in the form of radiotherapy or some other adjuvant treatment was advised after the excision of the swelling? Third, during surgery, did they put something inside to cover up the defect? Like Shanai sir was mentioning, no, whether the patient underwent grafting or not. So because it was a primary surgery in the past, so you should find out anything was put inside in the form of mesh. Because you said the patient has undergone excision of the abdominal wall swelling.
Yes.
You mentioned that in the history.
Yes.
How did you find out that it is the abdominal wall swelling which he underwent the surgery? Why not inside the abdomen? From the history, how do you know that it was abdominal wall swelling? Not inside. Why not inside?
Yes.
Is it not?
Yes.
So whenever we have a case like this where the disease has come back in the same place, you have to go into the depth of the primary disease and primary surgical or whatever the treatment they will do. That will give a lot of information for the present diagnosis. Okay?
Yes.
Yes, sir. Srinivasan, sir.
No, sir. Let him continue. You can.
Sir, general examination.
Arul Kumaran, sir, you want to ask something?
Vinay, you told it is left side of the abdomen.
Yes, sir.
But to my knowledge, my visibility, it looks like it is in the lower part of the left chest.
It's the left side of the abdomen only, sir.
So I can see the lower rib cage, lower border of the left side rib cage, and it is just below the breast fold.
Yes, sir.
So if you look at this, you can answer our previous professor's question. So is it a skin, or if it is intra-abdominal, or it is a extra-abdominal? So if you look at the picture, it doesn't look like a intra-abdominal surgery, isn't it, on the left side? If it is on the right side, if it is more open, then we may think gallbladder open cholecystectomy. So if it is a left side scar like this, if you look into the picture, you can answer SAS question. Okay, that's all. Thank you, sir.
Yes, sir. I think it's a valid point. Actually, there are other films in which it is more clearer. He will show now. Slowly he will show.
Yes, sir. Yes, please. Continue.
Yes. So the patient was examined in sitting position, the pulse being 88 per minute, blood pressure in the right arm.
Slide change, Vinay. Click on the slide on the left side.
Yes.
4, 5.
The blood pressure being 130 by 70 millimeters of mercury in the right arm, temperature being normal. No signs of pallor, sinuses, icterus, lymphadenopathy, or edema were found. On examination, on inspection, a single swelling over the anterior abdominal wall towards the left, below the left breast was noticed. The medial border of the swelling was approximately 6 centimeters from the midline. The swelling measures about 8 centimeters vertically and 15 centimeters horizontally, bosselated in appearance, irregular borders, tense, distinct edges present without any pulsations. The skin over the swelling has a healed scar of size of approximately 7 centimeters and visible superficial vasculature are present. There are no discharging sinuses or bleeding points, and there is no cough impulse. On palpation, there is no local rise of temperature. The swelling is measured to be 9 centimeters vertically and 14 centimeters horizontally. No tenderness. The surface is irregular, variable in consistency. Few areas are soft and few are firm. No fluctuation present. Well-defined irregular margins are present. Skin over the swelling is not pinchable. The mobility of the swelling is present in both vertical and horizontal plane. In the head raising test, the swelling has become more prominent compared to the normal position, and mobility is restricted in the horizontal plane. There are no axillary lymph nodes palpable. Systemic examination.
Speak now. Go ahead.
Systemic examination. The abdomen is flat, umbilicus is central in position, soft, there is no tenderness present, and no organomechanic. The respiratory system, bilateral air entry is present without any added sounds. Cardiovascular system, both S1 and S2 were heard normally without any added sounds.
Now you can actually stop at this stage and invite questions for your inspection and palpation.
Yeah, Vinay.
Yes, sir.
Yeah, I had some clarification. Did you examine the patient in supine position or sitting and supine position?
In supine position, sir.
Okay, because your presentation was the swelling, inspectory finding was swelling was below the breast.
Yes, sir.
Okay. In the inspection, if I ask you to examine the patient in the sitting position by raising her hand,
yes.
So what is that I want to know on inspection from this swelling? If I insist that, yeah, you should examine inspection even in sitting position this patient and ask her to raise the hand above the head.
If the swelling is arising from the breast or not?
Not necessarily. This case. There is a definite gap between the lower border of the breast and the mass. Like previously, sir mentioned one point that for the question of whether it is, how do you know it is intra-abdominal or in the abdominal wall, she has undergone the surgery. So what is that you want to know on inspection for this? To know is the swelling is situated over the chest wall below the breast.
The costal margin visibility.
Exactly. That's what you should highlight on inspection in sitting position. Is the costal margin seen?
Yes.
Other than the lower border of the swelling. Is that seen, costal margin on inspection?
No, sir. Costal margin is not seen.
It is not seen. Swelling is overlying the costal margin.
Yes.
Okay. Is the upper part of the swelling is going over the costal margin?
Yes, sir. Upper margin is going over the costal margin.
Exactly. Now you tell me with this, what is your inference? Is it an abdominal swelling you want to present, or you want to present it as a chest wall swelling, or you want to present it as probably on either side?
It's on either side, so chest wall and the abdominal wall.
A very important inspectory finding you need to describe in this particular case. Okay.
Yes. Yes.
So visibility of the costal margin, the distance between the breast, lower border of the breast and the upper part of the margin, and the extent of the swelling going over the chest wall and over the abdominal wall.
Yes.
Indicating what is the inference of this? Probably this is a parietal wall swelling.
Yes.
See, one inspectory finding nicely describing the extent and appearance and not appearance of few findings will tell us that probably this is a swelling arising from the wall involving the chest wall and the abdominal wall.
Yes.
Is it not?
Yes.
Okay. Oh, thank you.
In the exam, because at the time of presentation, you would have completed the examination, right? At the time, if you want to tell the exact extent on inspection, you can incorporate your palpatory finding. Because as examiners, we may not know whether you looked into that during your inspection or palpation, right? You can modify your inspectory finding. Thank you.
Vinay, what is the plane of the swelling?
It is extra abdominal above the abdominal wall muscles.
But we said no, it is extending over the chest wall also.
Yes. Sir.
So if it is asked, you have to start with the skin, subcutaneous tissue, muscle, and bone. That's what the plane of any given swelling.
Okay.
There you said skin is so probably the skin is involved, and you said after making the abdominal muscle contract, you said the swelling became more prominent. Is it not?
Yes.
Okay, but it is extending over the chest wall. This test, the head raising test, is applicable if a swelling is limited to abdominal wall.
Abdominal wall.
But this you said it is extending over the costal margin into the chest wall.
Yes.
So any other test you would like to do other than just doing a head raising test to know the depth of the swelling?
The movement of the torso to the left and right.
Movement of
the torso of the body to the left and right.
No, for the abdomen, you made a head raising test to make the muscle taut. That's what you did. Okay. So any muscle do you get over the chest wall there so that you can do some actions and make the muscle taut in this case?
The external intercostal muscles.
External intercostal. What is the superficial? We should check for the superficial muscles. Intercostal muscles cannot be tested clinically.
Yes.
What are those two big muscles over the chest wall, one anteriorly and one laterally?
Laterally the serratus anterior and anteriorly the pectoralis major.
Yeah, very good. So here looking into the picture, looks like it has got a relation with the serratus anterior than pectoralis major.
Yes.
Okay, so you have to check for, how do you check for the serratus anterior?
Place the hands on the hips and
Hip,
press.
that is for pectoralis major, no? Over the hip is pectoralis major.
Yes, sir.
What is the action of serratus anterior? Otherwise called what? Do you make a patient to push something and check for movement before and after doing the action? So that's what you need to do. Serratus anterior also, plus abdominal, because it is going below the costal.
Yes.
By head raising test, you will be making rectus abdominis to contract, but the swelling is laterally placed.
Yes.
So how do you make lateral abdominal muscles to contract? What is the action to be done? Lateral abdominal wall muscle.
Head raising as well as tilting towards the opposite side.
No. You should be doing Valsalva maneuver to make lateral muscles to contract.
Okay.
If it is above the umbilicus midline, head raising, below the umbilicus midline, leg raising, laterally place any muscles to know the level, abdominal wall, Valsalva maneuver will be a better option. Okay? Cool. Thank you.
Vinay, what is your differential diagnosis here?
So, with this, I would like to make a differential diagnosis of a soft tissue sarcoma, which has recurred.
Why it is not a irreducible hernia?
One, there is no cough impulse present, and
Irreducible hernia.
second, the consistency is firm and soft in places.
In a case of irreducible hernia, what are the signs of hernia?
Tenderness and
Irreducible hernia.
there will not be any compression will not be there, and there will be tenderness present.
The cough impulse will be absent and it will be not a reducible swelling.
Yes.
Okay, so both the signs of the cardinal signs of the hernia will be absent in a case of irreducible hernia. And you can get, if there is like a omentum which is coming out there, big omentum is there, she's a fatty patient. So that can give you the form swelling in that area. And it is just for the discussion purpose. Okay, that should also come in your mind.
Okay.
That, okay. Why it is not a desmoid tumor?
The consistency is smooth consistency in desmoid, but here it is firm as well as cystic.
What is the usual site of the desmoid tumor? Usual.
Midline.
Not in the midline. They are over the rectus sheath. Okay, so they are over the rectus sheath.
Yes.
That is the usual common site for the desmoid tumor. Okay, so all these things should be your. Have you put any differential diagnosis here?
It was only soft tissue sarcoma as the provisional diagnosis.
But these should be the differential diagnosis.
Okay.
So if you think it is a soft tissue sarcoma, from which soft tissue it is coming out?
The subcutaneous tissue or the muscles of the abdominal wall or the chest wall.
What is the mobility of this lump?
Mobility is present both in horizontal and vertical plane in the supine position. But whereas while in this head raising test, it is restricted in horizontal plane.
So there is a restricted mobility is there on head raising test or leg raising?
Head raising.
And did you check for the serratus anterior here in this area?
No, I have not checked, sir.
How do you check for the serratus? And like there's a breast lump is there, you want to see further whether this lump is fixed to the serratus anterior or not. What maneuver you do? You ask the patient either to press you or press against the wall. Okay, then the serratus anterior will become taut. Okay, so the same should have been done in this also, because this is lying in that area. That should have been done in this patient. Okay. So you are going to tell about the biopsy report of this patient. You said that we'll be tell about that.
Previous histopathology report was shown to us, which was reported as fibrosarcomatous dermatofibrosarcoma protuberance with positive skin margins and circumferential margins.
So when they asked you when you are given a soft tissue sarcoma, when examiner asks you probable diagnosis, Dr. Ajay Khanna sir was asking you what are the differential diagnoses. You should have, even though you know this diagnosis is a different issue, but if you look at this swelling, abdominal wall, firstly it is abdominal wall, and that kind of a protuberance, whatever you have written there, so much is. So you could have probably mentioned. Keeping that in mind, I would like to consider like that. Anyways, so I only told him to write like this, sir, so that to have the discussion. That's all, because the report is already there with him. So
what do you understand by dermatofibrosarcoma protuberance? What is the meaning of that?
The swelling is bossylated and multiple protrusions seen from the swelling.
So from where it is coming out? Which part of the soft tissue this sarcoma is coming out?
It's from the subcutaneous tissue and the.
Is it from the subcutaneous tissue?
Yes,
so that will be liposarcoma. If it is subcutaneous tissue is there, that should be liposarcoma then.
When you look at the name,
It's the skin and the subcutaneous tissue.
You see, its name is dermatofibrosarcoma. So from which structure it is coming out?
Dermis and the underlying layers.
Yes, from the dermis. So there is a fibrous tissue there in the dermis, and this tumor is coming out from that dermis. That is why it is, and protuberance, it is protruding outside. So it's like a big swelling coming out. That is why it is called as a dermatofibrosarcoma protuberance. And what does that mean? Positive skin margins and circumferential margins?
The tumor is infiltrating into the skin and the epidermis, as well as the margins of this excised swelling were with the tumor cells.
So do you think this was a proper excision which was done for this patient?
No, sir. And that is not an.
Was it done local anesthesia at that time?
Those details were not available with us. Only this HP report was shown to us.
Okay, so how you are going to work up this patient now?
So now, since it is a recurrence, we would like to do a metastatic workup as well.
Will you like to confirm your diagnosis first? Are you happy with this biopsy report? Are you happy with this biopsy report? Or you want to do
furthermore details of IHC markers can be done?
Yes, you have to do the IHC markers. So in this patient, you have to do a biopsy again.
Yes.
If the specimen is not available, or even if it is now as a tumor which was not treated properly, so you have to at least do a, what type of the biopsy you will do in this patient?
Core needle biopsy.
Yes, you will do a core needle biopsy. Okay, and in the core needle biopsy, you have to see that what is there and what are the various ISC markers. So what ISC markers you do for the sarcomas?
Desmin and S100 markers.
Okay. Has it been done in this patient?
We didn't do a core needle biopsy. We took her for wide local excision.
Okay. So you did a core needle biopsy and it came out to be that it is a case of a dermatofibrosarcoma protuberance. Okay. What other investigations you are going to carry out?
Can you show that slide showing that investigation? Yeah, explain that.
So, so this we had done CT abdomen, pelvis, and thorax to look for any metastasis.
Yes.
So first thing is this is a bossulated swelling which is hypoenhancing in the right upper abdomen and the chest wall, which is not infiltrating into the underlying musculature or the ribs.
Okay.
Apart from that, there was a subtle surrounding facial fat stranding seen without any calcification or hemorrhage.
Okay. Any other investigation done for this patient?
No, so only this much was done.
Have you done the X-ray of the chest of this patient?
A CT thorax was done, which had shown no metastasis.
Okay. And the biopsy report is awaited, is it?
The biopsy report is here. Sir. We had actually taken her wide local excision. We had taken a margin of about 5 centimeters. And we had sent the specimen to frozen section, and the margins are as mentioned here. And the final histopathology was fibrosarcomatous transformation in dermatofibrosarcoma protuberance, grade 2, with all margins to be negative. And these are the IHC markers which were done: CD34, Desmin, KI67, and P53, which was positive.
So how did you cover the defect?
We had closed it primarily, sir.
It could be closed primarily?
Yes, sir.
It's a big defect, isn't it?
Yes, sir. It's a big defect, but
Can you show the picture where it has been approximated? Do you have that picture?
We don't have that picture.
If you're not able to approximate that, how will you cover this defect?
Plan for a skin graft.
Which type of the skin graft?
Partial thickness skin graft.
Tell what is the difference between a partial thickness skin graft and a full thickness skin graft?
In the partial thickness skin graft, it is the epidermis and the upper 1/3 of the dermis present. Whereas in the full thickness, it is the epidermis and the dermis, which is taken.
In this scenario, you find that you have opened the chest because of the infiltration while you are going for the wide excision, and also you opened up the abdomen also, part of that. How you are going to cover that defect?
We can plan for a flap.
See, when I sir asked about chest,
I'm not pretty sure about that.
Yeah, you have to cover it with some flap, but then you have to also give the support there. So if the abdomen is open, you are going to put a mesh there. Okay, even for the chest also, you are going to put Probably some mesh there in that area. And then you are going to put a flap over that.
What kind of mesh you will place over the chest, Vinay? Sir told the answer, but for the abdomen, you will choose some kind of mesh. For the chest, you will choose some other kind of mesh.
The abdomen, it would be a proline mesh.
Okay.
So chest, I'm not sure.
It's titanium mesh.
Proline mesh is not a good option, isn't it? If you are not able to close the abdominal peritoneum or the sheath there, proline is not it. So you have to use something like a dual mesh which is there. Rather than using only the proline mesh for if there's a big defect is there in the abdominal wall where the viscera are exposed.
Yes.
You are not able to close the peritoneum, you are not able to close. Okay, so in this patient, margins are negative. What is your further treatment for this patient?
Further session of radiotherapy can be planned for the patient to prevent another recurrence.
So you are planning for the radiotherapy in this patient?
We had plans, but the patient did not turn up again.
Like in a case of desmoid tumor, do you plan the radiotherapy? Or these low-grade sarcomas, you plan for the radiotherapy?
Low grade,
Even if all the margins are negative?
Low grade, we don't plan for radiotherapy, but this dermatofibrosarcoma is a high grade and it is a recurrence. There are further more chances for it to recur again.
Dr. Shenoy, I'm not very sure about that.
Is there any role of medical management? Chemotherapy. Is there any role in this case? What is the role of imatinib in this patient?
Sir, basically the case was not my unit case basically, but I just want to keep you informed that patient came with the recurrence and wide excision has been done by different unit persons. The reconstruction was possible by direct closure. This was put in a tumor board. Looking at the patient's background, etc., etc., they said probably you can give radiation for this patient. That's all. I don't know about the imatinib, whether they had recommended, because it doesn't belong to my unit case. I'm not sure, sir.
Okay, sir. And when I suppose if you want to reduce the raw area, so is there any role of most micrographic surgery in this patient? Because you told the answer, you did something for this patient. What is most micrographic surgery?
Usually done in basal cell carcinoma, where multiple layers of the tumor are taken and it is observed under the microscope until we get a negative margin.
Yes. Can you apply that principle here? Because you want to reduce the raw area so that you told you want to cover it primarily. So if that was in your mind, is there any role of most micrographic surgery? That principle can be applied here.
Yes, it can be applied.
No. See, the dermatofibrosarcoma protuberance is very prone for recurrence. So you can't have this kind of most micrographic surgery can be applied here and all. So we have to give a very radical clearance. Otherwise, it will go for a recurrence. It is very, very notable for recurrence. So I don't think there is a role for most micrographic surgery in this case of dermatofibrosarcoma protuberance.
So it is because of the recurrence, or if it is a primary one, shall we try?
Never, because the unique feature of dermatofibrosarcoma protuberans is recurrence. In spite of giving 2 centimeter, 3 centimeter clearance, it recurs. So whereas in most micrographic surgery, we are going for millimeters. We are removing by millimeters, where what I'm saying is, even if you give 2 or 3 centimeter clearance, this recurs very commonly. Dermatofibrosarcoma protuberans recurs commonly. So the application of this does not have its place.
I have got some 4 or 5 cases only experience of this, sir. One in the abdominal wall, one in the actually breast region, one in the lateral side. In all these patients, even after the clearance, the radiotherapy people said we can irradiate. That the benefits, we were not very sure about that, but they said they have irradiated earlier, not in recently. Recently, I have not done any dermatofibrosarcoma. And here, I was told that base was only 1 millimeter. If you see that, it's not infiltrating, whereas on the lateral margin, medial, superior, inferior, everywhere it is there, except the base.
Shanai sir.
Hello, yes.
Sir, Shanai sir.
Yes.
Hello.
Sir, kelta illa, sir.
Kelta illa, sir.
Yeah, now we can hear.
Yes, sir. Yes, sir. Sir, to add to your explanation, this is a locally malignant tumor. In fact, it's a locally malignant tumor. This is one of the indication for upfront radiotherapy following even a primary excision of the tumor, in spite of having all the margin and the depth being free of the tumor.
Vinay, you had 1 or 2 slides on the theory of this, no? So just 1 or 2 slides. He had that little bit of literature review also. We normally, when they do this in the clinical presentation, or we ask them to also do some little bit of review of the literature. It's for the benefit of everyone. Is it there now with you?
No, sir. It's not there.
Huh?
It's not there.
Okay, then what? Anything? Any other questions, sir? From
that last question, when you told you want to do metastatic workup in this patient, right? After the proven case of dermatofibrosarcoma, still would you like to do extensive metastatic workup, or the CT chest and abdomen it is enough?
So common metastasis to the lungs. So and lungs and the liver. So CT chest and abdomen would do.
Because it is very rarely metastasis distally, right?
Yes.
And it is a very interesting case. In our career, in my surgical career, about only 1 case I have seen. Right, I passed out in 2005. Till date, only 1 case I have seen. It is very rare. It is a very nice, interesting case. You brought back the nostalgic memory of me when I was doing my MS and MMC under Professor Gunasagaran sir. He's a surgical oncologist. Right, it's a very interesting case. Very nice to recollect my memories. Thank you.
That's what I said. I have operated only 4 patients of this in 35 years, sir. So
Okay.
only 4 cases, and that's the reason why I said we'll present this as a short case. It actually case doesn't belong to our personal
It's a
unit,
nice case.
our institution. So that's the reason I told Kanak, well, we'll present this as a short case.
Okay, sir.
The whole purpose of this is, if you look at that lesion itself, it's a spotter, sir, almost spotter. If see how it really, see that itself is a very classical, once this look is there, actually it's not very clear in this, but in our computer it looks thin veins also you can see very nicely. If you can enlarge this picture also, Vinay, you may be able to show this as a, yes, yeah, enlarge it further. Yeah, that's correct. So postgraduate should be able to present this for all the clinical. Lot of findings are in this patient. That is the main purpose of the PG. That's the reason I told the thin vein, shiny surface, nodular or bossulated, restricted mobility on contraction of the lateral abdominal muscles as well as the rectus abdominis. There is a costal margin, little bit obliteration actually. Basically, I have not seen this patient, but I just want to tell you the findings based on what he had shown me some slides. And skin incision is there. That skin area is puckered. So good findings are there. So that's the reason I told him present.
So thank you, sir. Thank you for bringing this case. Thank you, Vinay.
Thank you, sir.
I was just seeing the net at this time that whether we can go over the Mohs surgery or not. In fact, it has been described for the dermatofibrosarcoma protuberance. So what we thought probably we cannot do it. It is described for the dermatofibrosarcoma protuberance.
So some of the literature says we can do Mohs micrographic principle. We can apply that principle here, sir.
Dr. Karakwel, can we
Thank you, sir. Thank you for taking this case. But I am sure, sir, even I have seen, I think this is the third case I'm coming across. But because in various conferences we get to see rare case presentations like that. So definitely it is in single digit only, sir. But my colleague has recently got one case like this. It was a third time recurrence, sir, within a short period, in spite of giving RT and in spite of getting wide local excision. He did in fact a full thickness excision and they rotated the gluteus maximus flap and all those things. Sir. But unfortunately, it recurs very rampantly. Sir.
That's why these are the tumor which is as rightly we discussed as locally recurrent tumor. There's a local recurrence is very much known.
Yes,
like
sir. Yes, sir.
Like we talk in Phyllodes tumor here, and even
exactly.
there are some tumors which are very difficult to treat, including desmoids and all that thing, which occur in the abdominal wall. Even though there we call it as a benign, still they have got a high chance of a recurrence. So that's what is one of the things which PGs also should know during the management. So as wide excision as possible, that should be the principle.
Yes, Rajiv Sinha, sir, are you with us, sir?
Yes, I'm very much there.
Any other part? Sir, please share your thoughts, sir. How is your experience like, sir? How many cases have you seen?
No, we have done, I think, about 7 or 8 cases. Most of them were desmoids and wide excision, a few were recurrences, and basically required a mesh implantation once you do a wide excision. Because some of these, they also have a tendency of growing inside through the peritoneum. We have seen a few patients going through the peritoneum. It's been mentioned, even desmoids are mentioned to have an intraperitoneal extension. So that becomes a major problem.
Kanakwel, for the desmoid and all, they mention about including the Sulindac, etc. Some of the drugs after the treatment. But this is coming from the skin itself. So so that's why the drug therapy is not there for this. So to prevent the
Probably
recurrence.
the lesion, like the medicine cannot reach the tumor possibly, right, sir? I mean to understand that.
Yes, 3 months back, I also got a case of a dermatofibrosarcoma protuberance, but that was on the left shoulder.
Okay, sir.
So I did a wide excision of that, and then for closing that, I use the limber flap for that. As we do for the pylonodontal sinus, we use the limber flap for coverage of that.
But what was the result, sir? Long-term result?
No, I think it is only 3 months back we operated that. So till the last follow-up is okay, but I have not given any radiotherapy or any other treatment to this patient. The patient is just on the follow-up.
But if you're lucky, I think a wide excision prevents a recurrence. If you're lucky enough and you do a wide excision, often
Yes,
it's
sir.
going to recur.
I understand, sir. I understand. Anyway, any other faculty would like to contribute any information, or can we call it as a close? I think, sir, Rajiv Sinha, sir, Arun Kumar, sir, anyone would like to add up? Can we call it a close, sir?
Yes, sir, I think we have had a good discussion. The presentation was above average.
Thank you very much, sir. I think
You seem to be in a car, Dr. Kanagave. You seem to be in a car. You're sitting in a car?
Sir, actually, no, sir. I'm still in the hospital only. If I sit in the car, I will not be disturbed, sir. That is the idea. Nothing more. I have to go back to see the patient. My OPD is in the evening, sir. That is how our system. I work for a mission hospital, sir.
Okay.
So my call days are Mondays and Thursdays. So I have to stay back because night time only all the PGs will be available. So I slowly take them for rounds and teach them. Fridays, of course, we don't teach, but my other two colleagues are on leave. Sir. One colleague is having corona now, so he is in home isolation, and the other two colleagues have admission for daughter in medical college like that. Sir. So I am the only person in the department running, sir. Only junior colleagues are there.
Good, good.
Okay, sir. Good night, sir.
Okay, good night, everybody.
Good night,
Yeah.
everyone.
Good evening. Good night, sir. Good night,
Good
sir.
night, sir.
Thank you very much, everyone. Thank you, all the faculty. Thank you, both the students. Do you have any questions to ask the faculty? Normally, we definitely allow the students to ask. He is already there. Thank you very much, sir. Thank you, everyone.
Thank you.
Thank you, sir. Thank you, Ananda.
Thank you, sir.
Karna, sir. Thank you, sir.